Welcome to the Deep Dive, your shortcut to becoming incredibly well-informed. Today, we're taking a really deep dive into the updated Society for Vascular Surgery Clinical Practice Guidelines, specifically for the management of extracranial cerebrovascular disease. Now, this isn't just a minor update, is it? It feels like a pretty critical reevaluation.
Oh, absolutely. It's a significant reevaluation of how we approach stroke prevention and treatment, particularly in patients with carotid bifurcation stenosis.
Right.
The evidence landscape has, well, it's evolved quite a bit since the 2011 guidelines.
So new trials, new thinking.
Exactly. New randomized controlled trials and maybe a renewed emphasis, I'd say, on modern medical management. It's shifting the conversation.
Okay. So our mission today is really to distill the most important, actionable insights from this big document. And it's tailored specifically for you, the specialist clinician who's making these calls every day. We're going to zero in on 5 key areas that the Society for Vascular Surgery Committee prioritized. We want to give you rigorous detail, but also, practical knowledge.
Think of this as your high-level roadmap. We're hitting the most pressing questions in extracranial cerebrovascular disease management.
Okay, lay them out for us. What are the 5?
All right. First, is carotid endarterectomy, or CEA, recommended over maximal medical therapy for low-risk asymptomatic patients? That's a big one.
Always a key question. Okay, number 2.
Second, how does CEA stack up against transfemoral carotid artery stenting, TFCAS, for low surgical risk patients with symptomatic carotid artery stenosis, say, greater than 50%?
CEA versus stenting, the classic debate. Got it. Third,
what's the optimal timing for carotid intervention when a patient presents with an acute stroke? Timing is critical there.
Hugely critical. Okay.
Fourth, we'll dive into screening, specifically the recommendations for screening asymptomatic patients. We'll look at the general population, high-risk groups, and what imaging works best.
Screening, always controversial. And the last one.
And finally, number 5, we tackle that complex challenge of combined disease. What's the optimal sequence of intervention for patients who have both carotid and coronary artery disease?
Okay, a really comprehensive agenda. So if you're ready to get incredibly well-informed on these latest guidelines, let's unpack this. Context and background, evolution of guidelines and methodology. All right, before we jump into the specific recommendations, maybe let's set the stage a bit. Managing extracranial cerebrovascular disease, it's been studied intensely for decades, hasn't it? Especially since CEA came along.
Oh, definitely. And what's really fascinating is the historical journey of CEA itself. Initially, there were hopes it could actually reverse existing stroke deficits.
Really? I didn't realize that was the initial hope.
Yeah, but that was, well, quickly disproven. Its role got largely defined by early work, like the joint study on the extracranial circulation. That study established its place for treating minor stroke, TIA, and that condition, amaurosis fugax, the temporary vision loss.
Right. And then things changed with better surgery and imaging.
Precisely. Surgical techniques got refined, non-invasive imaging improved dramatically, and CEA's role shifted quite significantly. It largely became a prophylactic tool. The goal shifted to preventing major strokes, primarily in asymptomatic patients or those with just transient symptoms.
And large trials cemented that role.
Yes, large prospective randomized trials really solidified CEA's efficacy in stroke prevention.
Okay, so CEA is established, but then here comes the disruption. Carotid artery stenting, CAS, the catheter-based option. How did that start to change the landscape?
Well, it introduced significant complexity, no doubt about it. We're talking about, roughly 135,000 carotid interventions each year in the U.S. alone?
Wow, that many?
Yeah, and a growing chunk of those are catheter-based, CAS. This brought multiple specialties into the mix, vascular surgeons, interventional cardiologists, radiologists, often with, shall we say, non-overlapping expertise.
Which leads to conflicting data, I imagine.
Exactly. Conflicting literature, different perspectives, and a clear need for updated, unified guidance. The 2011 SVS Guidelines were a first step, but the evidence just keeps evolving. This new update reflects that continuous process.
So given all that complexity, how did the committee actually tackle this? What was their methodology for these new guidelines?
They were very rigorous. The writing committee first identified these 5 critical clinical questions we just outlined. These really mirror the dilemmas clinicians face daily.
Okay.
Then, to answer them, they commissioned a systematic review and meta-analysis from the Mayo Clinic Evidence Practice Center. They used the PICO framework.
PICO. Remind us what that stands for.
Sure. Think of it as a structured way to frame a clinical question. P is the patient population. I is the intervention being studied, C is the comparison treatment, and O represents the critical patient outcomes.
So it ensures they're comparing apples to apples, essentially.
Pretty much. It ensures a systematic and rigorous evaluation, focusing on patient-important outcomes. And for these guidelines, stroke prevention was paramount.
And the recommendations themselves, they use the grade approach.
Correct. Great. That's the grades of recommendation, assessment, development, and evaluation system. It rates the certainty of the evidence. A for high, B moderate, C low.
Okay.
And then the recommendations are graded as strong, which is grade 1, or weak conditional grade 2.
Can you give us a quick analogy for grade? How should clinicians think about those grades?
Sure. Think of it like maybe traffic lights.
Mhm.
Grade 1, strong, is like a green light. The evidence is clear. The benefits strongly outweigh risks. Proceed with this standard of care. Grade 2, weak conditional, is more like a yellow light. Benefits and risks are more closely balanced, or the evidence isn't as strong. Proceed with caution, and definitely involve shared decision-making with the patient.
That's helpful. So it's not just about the evidence quality, but the balance of everything.
Exactly. Grade considers evidence certainty, the balance of desirable versus undesirable effects, patient values and preferences, costs. It's a comprehensive framework, adopted by over 100 organizations now.
What specifically struck you about how they applied this framework in these guidelines?
Well, a couple of things. One was the absolute priority given to stroke prevention. That drove some strong recommendations, like for timing of revascularization after stroke, even when direct trial evidence was maybe more variable. They weighted avoiding neurological worsening very heavily.
Okay, makes sense.
Conversely, look at screening. They made a strong recommendation against routine screening for average risk folks. Why? Because there just weren't comparative studies showing it actually improved outcomes like stroke or death, only studies showing it found more stenosis.
So a very patient outcome-focused approach.
Precisely. Patient-centric, and I'd say appropriately risk-averse when the evidence for benefit wasn't clear. 2. Question 1. Is carotid endarterectomy recommended over maximal medical therapy for asymptomatic carotid stenosis in low surgical risk patients?
All right, let's dive into the first big question. Asymptomatic patients, low surgical risk, severe stenosis. CEA versus just medical therapy, what do the guidelines say?
Okay, recommendation 1.1 is pretty clear on this. It states, for low surgical risk patients with asymptomatic carotid bifurcation, atherosclerosis, and stenosis greater than 70%. Documented properly, of course.
Right, validated imaging.
Yes, validated duplex ultrasound or CT angiography. For these patients, the guideline recommends carotid endarterectomy with best medical therapy instead of maximal medical therapy alone.
Okay, so CEA plus meds beats meds alone.
Yes, specifically for the long-term prevention of stroke and death. And this is a grade 1 recommendation, so strong. The quality of evidence supporting it is rated B, which is moderate.
Grade 1B. So even with modern medical therapy improving, CEA still holds a strong recommendation here. That's important.
It is. And the foundation for this comes from some really pivotal randomized controlled trials. You have ACS, the Asymptomatic Carotid Atherosclerosis Study.
Right, ECS, what did that show?
ACS randomized over 1,600 patients. It clearly demonstrated CEA was superior. For patients with greater than 60% asymptomatic stenosis, the stroke and death rate in the surgical group was 5.1%. In the medically treated group, it was 11.0%.
Wow, that's a big difference.
It is, an aggregate risk reduction of 53%. ACAS recommended CEA for patients under 80 as long as the surgeon's complication rate, stroke, and mortality combined was under 3%.
Okay, and wasn't there another big trial, ACST?
Yes, the Asymptomatic Carotid Surgery Trial, ACST. Over 3,000 patients. It showed a consistent advantage for CEA too. Looking at stroke and death in 5 years, it was 4.1% for CEA versus 10.0% for maximal medical therapy.
And long-term follow-up.
Also supported CEA. The 10-year data from ACST, reported by Halliday and colleagues, confirmed lower perioperative and long-term stroke rates for the CEA group in patients under 75.
Okay, compelling data. But what about that criticism we hear sometimes, that the medical therapy in those older trials wasn't really up to today's standards, particularly no statins back then?
That's a really important point and a fair criticism. The medical arms in ACS and ACST didn't routinely include statins, which are standard now.
So does that invalidate the findings?
Not entirely. An interesting subgroup analysis from ACST looks specifically at patients who are receiving some form of lipid-lowering medication. Even in that group, CEA still resulted in a lower annual stroke incidence, 0.7% versus 1.3%. So still a benefit, though perhaps smaller.
I see. But the definitive answer on CEA versus modern medical therapy is still pending.
That's right. We are eagerly awaiting results from major ongoing trials like SPACE-2 and CREST-2. They are specifically designed to answer that exact question head-to-head.
Okay. Now, another concern often raised, are the low complication rates seen in these trials achievable in everyday practice, outside of those centers of excellence?
Another critical question. And yes, some critics did suggest the trials were done in highly selected settings with top surgeons.
But what does real-world data show?
That's the reassuring part. Subsequent large registry data, we're talking National Surgical Quality Improvement Program, state databases, Medicare data, tens of thousands of patients.
Big numbers.
Huge numbers. They've consistently shown combined stroke and death rates after CEA for asymptomatic patients that are often around 2.2%, maybe slightly higher for symptomatic patients, but still well within recommended thresholds.
So the good results are generally achievable.
The evidence suggests yes. These favorable outcomes seem broadly achievable in general clinical practice, not just in the rarefied air of clinical trials.
Okay, so let's try to summarize question 1 for the clinician listening. The core takeaway seems to be, for your low-risk asymptomatic patient with documented severe greater than 70% carotid stenosis, CEA combined with best medical therapy remains the strongly recommended approach, grade 1B, for long-term stroke prevention. This builds on consistent trial evidence, and real-world data suggests the results are achievable. Is that fair?
That's a very fair summary. CEA plus BMT is the standard.
All right, maybe this is a good point for a quick clinical scenario, like a board-style question based on this.
I'm good.
Okay. Consider this. A 68-year-old male, otherwise healthy, no history of stroke or TIA. He's found to have an asymptomatic 80% left internal carotid artery stenosis on a screening duplex ultrasound. He's considered low surgical risk. According to current guidelines, which of the following is the most appropriate long-term management strategy for preventing stroke and death? A, maximal medical therapy alone, including high-dose statins and antiplatelet agents. B, immediate carotid endarterectomy combined with best medical therapy. C, carotid artery stenting with best medical therapy. D, regular surveillance with duplex ultrasound every 6 months. We'll pause for a moment there. Okay, what's the answer and rationale?
The correct answer is B, immediate carotid endarterectomy combined with best medical therapy. The rationale comes directly from recommendation 1.1 we just discussed. For low surgical risk patients with asymptomatic stenosis greater than 70%, like this 80% stenosis, CEA plus best medical therapy is recommended over maximal medical therapy alone. That's the grade 1B recommendation, supported by trials like ACS and ACST. Options A and D represent less effective strategies according to the evidence, and option C, stenting, isn't the primary recommendation for asymptomatic disease in standard risk patients compared to CEA, though that's more relevant to question 2.
Excellent breakdown. Let's move on then. Question 2. Is carotid endarterectomy recommended over transfemoral carotid artery stenting for low surgical risk patients with symptomatic carotid artery stenosis of greater than 50%? Okay. Question 2. Now we're talking about symptomatic patients. Low surgical risk, stenosis over 50%. How does CEA compare to transfemoral CAS or TFCAS?
Right. Recommendation 2.1 addresses this head-on. It states, we recommend CEA over TFCAS in low and standard risk patients with greater than 50% symptomatic carotid artery stenosis. And this one is a grade 1 strong recommendation, but the quality of evidence is A high. So grade 1A.
Grade 1A, that's about as strong as it gets. Why such a strong recommendation favoring CEA here?
It really comes down to the primary goal, stroke prevention. The committee explicitly stated they place more emphasis on preventing stroke and procedurally related death compared to, say, peri-procedural myocardial infarction, or MI.
Because stroke has a bigger impact on quality of life.
Precisely. Stroke often has a much greater long-term impact on patients' function and quality of life than an uncomplicated MI might.
Okay. And just to quickly confirm, for symptomatic patients, if the stenosis is less than 50%, intervention usually isn't recommended, right?
That's correct. Big trials like ECST, the European Carotid Surgery Trial, and NASCET, North American Symptomatic Carotid Endarterectomy Trial, showed pretty clearly that for less than 50% symptomatic stenosis, CEA didn't actually reduce neurologic events compared to medical management. It might even increase morbidity.
But over 50% CEA is beneficial compared to meds alone.
Definitely. Both NASCET and ECS demonstrated a significant benefit for CEA over medical therapy in symptomatic patients with greater than 50% stenosis. And that benefit increased as the stenosis got more severe.
Okay, so CEA beats meds for significant symptomatic stenosis. Now, let's get back to CEA versus TFCAS. What did the head-to-head trials show consistently?
This is where the grade 1A evidence comes from. Several major trials compared them directly. EVA3S, SPACE, ICSS, and the big one, CREST.
Great, Crest. What was the pattern across these trials?
The consistent pattern, especially when you look at the peri-procedural period, say, the first 30 days, was that transfemoral CAS was associated with a significantly higher risk of stroke or death compared to CEA in these symptomatic patients.
Significantly higher. Like how much higher?
Often around double the risk. For example, in ICSS, the International Carotid Stenting Study, the peri-procedural stroke risk was 7.7% with CAS versus 4.1% with CEA.
Okay.
In CREST, looking specifically at symptomatic patients, the peri-procedural rate of stroke and death was 6.0% after TFCAS, compared to just 3.2% after CEA. That's a statistically significant difference.
Were there any trade-offs, like lower MI rates with stenting?
CREST did show lower MI rates after CAS, but interestingly, for the symptomatic subgroup in CREST, that difference in MI wasn't statistically significant. The dominant finding was the higher stroke risk with TFCA.
What about pooled analyses, combining data from multiple trials?
Yes, the Carotid Stenosis Trialists Collaboration, or CSTC, did a meta-analysis of over 4,700 patients from 4 of these trials. It showed a clear peri-procedural hazard ratio favoring CEA. The difference was particularly noticeable in older patients. If you excluded patients in their 80s, the 30-day stroke and death rate was significantly lower for CEA, about 2.6% versus 5.6% for CES.
So the early risk is definitely lower with CEA. What about long-term outcomes? Does CAS catch up?
That's a key question. A pre-planned pooled analysis looked at individual patient data from EVA3S, SPACE, ICSS, and CREST, following patients for a median of around 2 to 7 years. It confirmed that the risk of stroke or death within 120 days, that extended peri-procedural window, was lower for CEA 5.5% versus CAS 8.7%.
Okay.
Now, after that initial period, the annual rate of late ipsilateral stroke was actually similar between the two procedures. This suggests similar durability.
But the initial hit from the higher procedural risk with CAS means the overall long-term outcomes still favor CEA.
Exactly. Because CEA starts with that lower upfront risk, even if the long-term durability is similar, the overall event-free survival related to stroke and death tends to favor CEA.
Do these findings hold up in the real world outside of controlled trials?
Yes, and that's important. There was concern because trial operators were often highly experienced. Some data suggested many real-world physicians wouldn't meet trial criteria for volume or complication rates. However, large registries like the Vascular Study Group of New England and the Vascular Quality Initiative, VQI, have consistently shown higher in-hospital stroke and death rates for symptomatic patients treated with CAS compared to CEA. So the trial findings seem to be reflected, directionally at least, in broader clinical practice.
Okay, that's a robust case for CEA over TFCAS in this group. Now, let's shift slightly. What about TCR? Transcarotid Artery Revascularization, it seems to be gaining a lot of traction. How does it fit in?
TCR is definitely the exciting development in this space. It uses dynamic flow reversal during stenting, accessed via the neck rather than the groin.
And the early data?
Very promising. Early studies, some using sensitive diffusion-weighted MRI, suggested TCR had similar rates of new brain infarcts to CEA, and maybe 2 to 3-fold lower rates compared to transfemoral CAS.
Oh.
Then you have the Roadster trials. Roadster 1 and 2 reported really excellent 30-day stroke and death rates, just 0.6% for symptomatic patients in Roadster 2.
0.6%, that's very low.
Extremely low. And more recently, a large VQI analysis compared over 6,000 propensity-matched TCR and CEA patients. For symptomatic patients, it found no significant difference in the rate of in-hospital stroke and death between TCR and CEA. It was 2.2% for TCR versus 2.6% for CEA.
So comparable safety to CEA in that analysis. Any other differences?
Yes, the VQI study also found TCR was associated with lower rates of cranial nerve injury and shorter hospital stays compared to CEA.
That sounds quite compelling. Is TCR now recommended alongside CEA for these low-risk symptomatic patients?
Not quite yet, according to these guidelines. While the data is very promising and TCR has an SVS clinical competency statement supporting its use, the vast majority of TCR procedures performed to date have been in patients considered high risk for CEA, either anatomically or medically. So the current data, while excellent, isn't considered sufficient yet to recommend TCI as a first-line alternative to CEA, specifically for low surgical risk symptomatic patients. However, it does appear to be superior, or at least preferable, to transfemoral CAS and potentially preferable to CEA in patients who are at high surgical risk.
Okay, so TCR is one to watch closely, especially as more data accumulates in lower risk populations.
Definitely.
So let's micro-recap question 2. For low to standard risk patients with symptomatic carotid stenosis over 50%, CEA is the strongly recommended grade 1A procedure over TFCA due to lower peri-procedural stroke death rates seen consistently in trials and registries. Long-term durability might be similar, but the initial safety favors CEA. TCR looks very promising, potentially matching CEA safety with other benefits, especially in high-risk patients, but its role in low-risk symptomatic patients needs more data before it challenges CEA head-on. Sound right?
That captures it perfectly.
All right, time for another board-style question.
Let's do it.
Okay. A 72-year-old male presents with a new transient ischemic attack affecting his left arm. Imaging reveals a 75% symptomatic right internal carotid artery stenosis. He is otherwise healthy and considered low surgical risk. Which revascularization strategy is most strongly recommended for this patient according to current guidelines? A. Transfemoral carotid artery stenting, TFCAS. B. Carotid Endarterectomy, CEA. C. Transcarotid Artery Revascularization, TCA. D. Maximal medical therapy alone with close follow-up. Quick pause again. All right, the answer. The correct answer is B. Carotid Endarterectomy, CEA. The rationale is recommendation 2.1, which we just discussed. It's a grade 1A recommendation favoring CEA over TFCAS for low and standard risk patients with symptomatic stenosis greater than 50%. This patient fits that profile perfectly. Option A, TFCAS, has higher peri-procedural risk. Option C, TCAR, while promising, isn't yet the primary recommendation for low-risk patients based on current guidelines. Option D, medical therapy alone, is inappropriate for symptomatic patient with 75% stenosis, as CEA offers significant benefit in stroke reduction.
Clear as day. Moving on to timing after stroke. 4. Question 3. What is the optimal timing of carotid intervention for patients presenting with acute stroke? Question 3 focuses on timing. A patient comes in with an acute stroke, and they also have significant carotid stenosis. When is the best time to intervene on the carotid?
This is a critical area with some very specific recommendations. Let's break them down. Recommendation 3.1 deals with patients who've had a recent stable stroke. That means a modified Rankin scale score of 0 to 2, minimal or no disability. For these stable stroke patients with symptomatic stenosis greater than 50%, the guidelines recommend carotid revascularization.
When?
As soon as the patient is neurologically stable after 48 hours, but definitely before 14 days from when the symptoms started. This is a grade 1, strong recommendation with moderate quality evidence, so grade 1B.
Okay, so a window between 48 hours and 14 days for stable strokes. What procedure?
Recommendation 3.2 clarifies that. In patients undergoing revascularization within that first 14 days, they recommend CEA rather than carotid stenting. That's also a grade 1 strong recommendation with moderate quality evidence, grade 1B.
CEA preferred in that early post-stroke window. Now, what about more severe strokes?
That's covered by recommendation 3.3, and it's crucial. The guidelines recommend against revascularization regardless of how tight the stenosis is for patients who had a disabling stroke. That means a Rankin score of 3 or greater, or if the infarct area is large, say greater than 30% of the middle cerebral artery territory, or if the patient has altered consciousness.
Why the contraindication?
The primary reason is to minimize the risk of postoperative parenchymal hemorrhage, or hemorrhagic transformation of the infarct. That risk is significantly higher in patients with large strokes or severe deficits. This is also a grade 1 strong recommendation, but the evidence quality is C, or low, so grade 1C.
So for severe strokes, wait and see.
Essentially, yes. These patients can be reevaluated for carotid intervention later if their neurologic recovery is satisfactory. But early intervention is contraindicated.
Got it. So when a stroke patient comes in, the carotid isn't always the first thing to address.
That's absolutely right. The immediate priority is always, if possible, to identify and reperfuse any intracranial blockages. That's time-sensitive brain salvage. For patients who aren't candidates for that, or who present later, then the carotid intervention is about preventing the next stroke.
Okay, so for those stable strokes, why that specific window after 48 hours but before 14 days? Why not immediately, or why not wait longer?
Good question. Waiting longer than 14 days significantly increases the risk of having another stroke, or TIA. Natural history studies show recurrence rates jumping by 10 to 20% if you wait beyond 2 weeks.
So waiting is risky. Why not go right away within the first 48 hours?
There's evidence suggesting that operating very early, within the first 48 hours, might carry a higher risk of perioperative complications, including hemorrhagic transformation or worsening deficits. For instance, that Swedish vascular registry analysis showed an 11.5% combined stroke death rate for surgery within the first 2 days, compared to rates between 3.6 and 5.4% when surgery was done later within that 2-week window. A multivariate analysis even suggested operating within the first 2 days had a more than 4-fold increased odds ratio for complications compared to operating between days 3 and 7.
So that brief delay, 48 hours or so, allows for stabilization.
Exactly. It allows for more complete patient evaluation, confirmation that the neurological deficit is stable or improving, and planning. It seems to hit a sweet spot between the risk of recurrence if you wait too long and the potential risk of very early intervention.
And what about using stenting, CAS, in this acute stroke setting? You mentioned CEA is preferred.
Right. The data on using CAS specifically for acute stroke patients is really scant. It's mostly anecdotal case reports. Because of that lack of robust data, you really can't draw firm conclusions about its benefits or risks in this specific setting. So CEA remains the procedure of choice within that 48-hour to 14-day window for stable stroke patients.
Okay, let's sum up question 3 on timing. For patients with a recent stable stroke, Rankin 02, and significant symptomatic stenosis, the goal is carotid revascularization, preferably CEA performed between 48 hours and 14 days after symptom onset, grade 1B. However, for disabling strokes, Rankin 3, large infarcts or altered consciousness, early revascularization is strongly contraindicated, grade 1C, due to hemorrhage risk, but they can be reassessed later. Does that cover it?
Yes, that's an accurate summary of the key timing principles.
Perfect. Ready for the board question?
Ready.
All right. A 60-year-old female presents with new, mild left-sided weakness. It developed 72 hours ago. Her modified Rankin scale score is 1. Brain imaging shows a small ischemic infarct, less than 10% of the right middle cerebral artery territory. Duplex ultrasound reveals a 60% symptomatic right internal carotid artery stenosis. What is the most appropriate next step in her management? A, immediate carotid endarterectomy within 24 hours. B, begin maximal medical therapy and observe for further neurological events. C, carotid endarterectomy should be performed as soon as neurologically stable, but definitively before 14 days from symptom onset. D, carotid artery stenting should be considered given the recent stroke. Pause for thought. Okay, the answer.
The correct answer here is C. Carotid endarterectomy should be performed as soon as neurologically stable, but definitively before 14 days from symptom onset. This patient fits the criteria in recommendation 3.1. Recent stable stroke, Rankin 1, small infarct. Symptomatic stenosis 50%, it's 60%, and she's presenting at 72 hours, which is past the initial 48-hour window. So CEA is indicated within the next 11 days, essentially. Option A is too early based on the evidence suggesting higher risk within 48 hours. Option B ignores the benefit of revascularization for preventing recurrence in symptomatic patients. Option D is incorrect because recommendation 3.2 specifically recommends CEA over CAS in this early post-stroke timeframe.
Nicely explained. Let's move on to screening. V. Question 4. Screening for carotid artery stenosis in asymptomatic patients. Okay, question 4 is all about screening asymptomatic individuals. This is divided into a few parts. First up, should we be screening the general population? A. Is screening for asymptomatic carotid stenosis recommended for the general population?
The guideline here, recommendation 4.1, is very clear. It states, we recommend against routine screening for clinically asymptomatic carotid artery stenosis in individuals without cerebrovascular symptoms or significant risk factors for carotid artery disease, and that's a grade 1. Strong recommendation with moderate quality evidence, grade 1B.
So a strong no to screening everybody walking down the street. What's the main reason? You mentioned it briefly earlier.
It really boils down to disease prevalence versus potential harm. For screening to be generally cost-effective and beneficial, the prevalence of the condition in this case, significant carotid stenosis, usually needs to be reasonably high, maybe 20% or more in the screened population.
And in the general population, it's much lower.
Much lower, typically less than 5%. When the prevalence is that low, you end up doing a lot of tests to find very few cases. More importantly, you increase the risk of false positives.
And false positives lead to
unnecessary anxiety for the patient, further potentially invasive testing, and sometimes even inappropriate interventions on stenosis that might never have caused a problem. The potential harms start to outweigh the potential benefits in a low-prevalence setting.
Makes sense. And other organizations agree.
Yes, this position aligns with recommendations from many groups, including the U.S. Preventive Services Task Force, National Stroke Association, and others.
Okay, so no general population screening, but what about specific high-risk groups? B, is screening for carotid stenosis recommended for high-risk asymptomatic patients?
Now here the recommendation shifts. Recommendation 4.2 states, In selected asymptomatic patients who are at an increased risk of carotid stenosis, we suggest screening, especially if those patients are willing to consider carotid intervention if significant stenosis is discovered. Now, this is a grade 2 weak recommendation with moderate quality evidence, grade 2B.
Grade 2B, so suggested, not strongly recommended, and only in selected high-risk groups. Who qualifies? What makes someone high-risk enough to warrant screening?
We're looking for groups where the prevalence of significant stenosis climbs significantly, ideally hitting that 20% mark or higher. The guidelines and supporting evidence point to several specific subsets.
Like who?
Okay, definitely patients with known lower extremity peripheral arterial disease, PAD. They consistently have a much higher rate of carotid stenosis.
Okay, PAD patients. Who else?
Patients undergoing coronary artery bypass surgery, CABG. Occult carotid stenosis is quite common in this group, and it can increase their perioperative stroke risk during the heart surgery. Screening is generally considered appropriate before CAB, especially in older patients or those with specific risk factors, like left main disease or smoking history.
CABG patients, got it. Any others based on risk factors?
Yes. The evidence suggests screening is reasonable for patients aged, say, 55 or 60 years or older, who have multiple traditional atherosclerotic risk factors. Think hypertension, hypercholesterolemia, current smoking, diabetes, maybe a strong family history of stroke. If they have 2 and especially 3 or more of these factors, their likelihood of having significant stenosis goes way up. Some studies showed prevalence reaching 40, even 60%, with 3 or 4 risk factors in older individuals.
So, age plus multiple risk factors. What about just hearing a brute?
A carotid brute on exam is interesting. By itself, it's not highly specific, maybe only a 25% positive predictive value for significant stenosis. However, its presence does indicate turbulent flow and increases the likelihood of underlying disease. So, particularly in someone who already has other risk factors, finding a brute would definitely strengthen the case for doing a duplex ultrasound.
Okay. What about patients with things like kidney failure or diabetes?
Yes, combinations involving those can push prevalence up too. For example, patients with renal failure plus diabetes, hypertension, or known coronary disease are likely high yield. Same for patients with hypertension, high cholesterol, and known coronary artery disease. The combination of risk factors is key.
Are there any groups where screening is not generally recommended, even if they seem high risk, like AAA patients or those with neck radiation?
Good question. For patients with abdominal aortic aneurysms, AAAs, the correlation with carotid stenosis isn't as strong as with PA or CAD. Prevalence is often below that 20% threshold. So routine screening isn't generally recommended just based on having a AAA unless they have other significant risk factors.
And neck radiation.
Patients with prior neck irradiation, especially more than 5 years ago, do have a significantly increased risk, maybe 8 times higher, of developing carotid stenosis. It often peaks around 15 years post-radiation. However, while some propose routine screening, it's not universally accepted without other traditional risk factors being present. The optimal timing and frequency aren't really defined.
So, focus screening on PA, pre-CABG, older patients with multiple risk factors, and maybe use a brute as a contributing factor.
That's a good summary of the highest yield groups where screening is suggested, grade 2B.
Okay, so if we are going to screen one of these high-risk individuals, what's the best test? C. What imaging test is best for screening for carotid stenosis in asymptomatic patients?
Recommendation 4.3 is very direct on this. It states, for asymptomatic patients undergoing screening for carotid artery stenosis, we recommend duplex ultrasound performed in an accredited vascular laboratory as the imaging modality of choice. It specifically recommends this instead of CTA, MRA, or other imaging. And this is another. Grade 1, strong recommendation with moderate evidence. Grade 1B.
Grade 1B for duplex ultrasound as the screening tool. Why is it so clearly preferred?
Several reasons. Duplex ultrasound is first and foremost safe, no radiation, no contrast risks. It's relatively expensive, it's readily available, and when performed in an accredited lab by experienced technologists, it's highly accurate and reliable for detecting and quantifying stenosis.
How accurate?
Sensitivity is generally quoted in the 85 to 92% range, with specificity around 84% for detecting significant stenosis. It uses well-validated criteria based on blood flow velocities, peak systolic and end diastolic velocities to estimate the degree of narrowing.
And it can look at the plaque itself, too.
Yes, that's another advantage. It can provide information on plaque morphology. Is it ulcerated, heterogeneous, echolucent? These features might indicate a higher risk plaque, independent of just the stenosis degree.
What are the downsides of duplex?
Its main limitations are that it's operator dependent. The quality of the scan depends on the technologist's skill. It can sometimes be difficult to get good images if there's heavy calcification in the vessel wall, or if the patient's neck anatomy is challenging, like with arterial tortuosity. And it doesn't visualize the entire vessel from the arch up into the brain perfectly.
So why not use CTA or MRA for screening then? They give great pictures.
They do give excellent anatomical detail, absolutely. CTA, computed tomography angiography, is fast and great for seeing calcification and the aortic arch origins. But it involves significant radiation exposure and iodinated contrast, which carries risks like allergy and kidney injury. Plus, it's much more expensive. MRA, magnetic resonance angiography, avoids radiation and often uses gadolinium contrast, which has a different risk profile. It can even be combined with brain MRI, but it's very expensive, takes longer, and isn't suitable for patients with certain metallic implants or severe claustrophobia. So because of the cost, radiation for CTA, contrast risks, and access issues, neither CTA nor MRA is appropriate for screening asymptomatic patients. They are excellent diagnostic tools if needed after an abnormal duplex or for preoperative planning, but not for initial screening.
And catheter angiography.
Definitely not for screening. It was once the gold standard for diagnosis, but it's invasive and carries a small but real risk of causing a stroke itself. It has essentially no role in screening asymptomatic disease.
Okay, let's try a mega recap for all of question 4 on screening. First, routine screening of the general asymptomatic population is not recommended, grade 1B, due to low prevalence and potential harms. Second, screening is suggested, grade 2B, for selected high-risk asymptomatic individuals, like those with PAD, pre-CIBG patients, or older individuals with multiple atherosclerotic risk factors, smoking, HTN, HLD, diabetes. A brute adds to the suspicion, but probably not just for AAA or neck radiation alone without other factors. Third, if you do screen, the imaging test of choice is unequivocally duplex ultrasound performed in an accredited vascular lab, grade 1B. CTA and MRA are diagnostic tools, not screening tools. How does that sound?
That sounds like a perfect summary of the screening recommendations.
Right. Final board question for this section.
Go for it.
A 65-year-old male comes for a routine physical. History includes hypertension, hypercholesterolemia, and he's an active smoker. No cerebrovascular symptoms. Yeah. On exam, you note a carotid brute. He asks if he needs screening for carotid artery disease. Based on current guidelines, what's the most appropriate recommendation? A, routine screening is not recommended for asymptomatic individuals. B, screening with CTA is recommended to accurately assess stenosis and plaque morphology. C, screening with duplex ultrasound is suggested given his multiple risk factors and the presence of a carotid brute. D, screening with MRA is preferred due to its ability to detect silent cerebral infarctions. Pause. Okay, your analysis.
The correct answer is C. Screening with duplex ultrasound is suggested given his multiple risk factors and the presence of a carotid brute. Here's why. While A is true for the general population, this patient falls into a high-risk category based on recommendation 4.2. He's over 55, has multiple risk factors, hypertension, hypercholesterolemia, active smoker, and he has a brute. This combination strongly suggests screening is appropriate. Grade 2B. Recommendation 4.3 then tells us the imaging modality of choice for screening is duplex ultrasound, grade 1B. Therefore, options B, CTA, and D, MRA, are incorrect as primary screening tools. C accurately reflects both the suggestion to screen this high-risk individual and the correct imaging modality.
Excellent. On to the final question about combined disease. 6 for 6. Question 5. What is the optimal sequence for intervention in patients with combined carotid artery stenosis and coronary artery disease? All right, the fifth and final question. This tackles that really challenging scenario. Patients who need intervention for both carotid stenosis and coronary artery disease, like needing CEBG. What's the best way to sequence these procedures?
Yeah, this is definitely complex, and the recommendations reflect that complexity and often the lower quality of evidence available. Let's start with recommendation 5.1. This is for patients with symptomatic carotid stenosis 50 to 99% who also need CABG. For them, the guidelines suggest performing CEA either before or concomitant with at the same time as the CABG.
Suggest. Why before or during?
The rationale is to potentially reduce the risk of stroke during or shortly after the CABG, which is a known risk period. But notice the wording suggest.
Yeah.
This is a grade 2 weak recommendation with low quality evidence, grade 2C. And crucially, it says the sequencing depends on the clinical presentation and institutional experience.
Grade 2C. So not a strong mandate. What about severe asymptomatic stenosis in CABG patients?
That's recommendation 5.2. This applies to patients with severe 70 to 99% bilateral asymptomatic carotid stenosis or severe asymptomatic stenosis on one side with an occlusion on the other. For this high-risk asymptomatic group needing CABG, the guidelines also suggest CEA before or concomitant with CABG. Again, it's a grade 2, weak recommendation with low-quality evidence, grade 2C.
Okay, same level of recommendation, suggesting intervention but with low certainty. What about choosing between CEA and CAS if carotid intervention is needed alongside coronary intervention?
That's recommendation 5.3. It says that if a patient requires carotid intervention, whether you stage it or do it synchronously with the coronary intervention, the decision between CEA and CAS should be determined by multiple factors. The timing of the procedures, the need for anticoagulation or antiplatelet therapy, which differs between CEA and CAS, the patient's specific anatomy, and other patient characteristics. This is also a grade 2 weak recommendation, but the evidence quality is slightly better, grade B moderate, so grade 2B.
So it sounds like across the board for combined disease, the recommendations are mostly weak suggestions, grade 2, with low to moderate evidence. No hard and fast rules.
That's a very accurate assessment. There's no single right sequence or approach that fits everyone. When you look at the observational studies comparing different sequences combined CA-CABG versus staging them with CABG first or CEA first, they generally show similar overall risks for death, stroke, and MI.
No clear winner in the sequence studies.
Not really. There were some small, non-significant trends.
Mhm.
Maybe a tiny bit more MI if CEA was done first, maybe a tiny bit more stroke if CABG was done first, but nothing definitive enough to make a strong universal recommendation.
And what about intervening on purely asymptomatic stenosis before CABG? You mentioned that's controversial.
Extremely controversial, especially for unilateral 70-99% asymptomatic stenosis. The stroke risk during CABG in these patients might actually be quite low, potentially less than 2%. So does adding a prophylactic carotid procedure really provide a net benefit? The few randomized trials and observational series comparing combined versus staged approaches in this group have been small and produce conflicting results. Really need larger studies here. What if CAS is considered in this combined setting? Any difference? Some observational data hinted at potentially lower mortality if CAS was performed before CABG, but again, this was based on small numbers and needs cautious interpretation. Pooled analyses comparing combined carotid intervention versus staging at first didn't show major differences for asymptomatic patients either, keeping the certainty low. And, this really highlights where patient values and preferences become absolutely critical. Well, a patient facing CABG already knows they have an increased stroke risk associated with the heart surgery. Some might strongly prefer to address a known significant carotid stenosis at the same time, hoping to minimize overall risk with just one major recovery period, even if the evidence for benefit isn't grade 1A.
So shared decision-making is absolutely essential here.
Paramount.
Mhm.
You have to discuss the uncertainties, the potential benefits, the potential risks of each approach, staging versus combined, CEA versus CAS. If a patient is highly symptomatic from one condition, say unstable angina or a very recent stroke, that might drive the decision to address that problem first. If the coronary disease can be handled with percutaneous coronary intervention, PCI, then that's usually done first, followed later by the carotid procedure.
Any other factors influencing the choice?
Sure, patient anatomy might make CAS or CEA technically easier or harder. The need for dual antiplatelet therapy after CAS versus maybe just aspirin after CEA can influence timing relative to CAG. Some centers might favor CEA under regional anesthesia just before CABG to avoid some risks of general anesthesia. It's very individualized.
Okay, let's try to micro-recap this complex final question. For patients needing both carotid intervention and CABG, if the carotid stenosis is symptomatic, 50-99%, doing CEA before or concomitant with CABG is suggested, grade 2C, but sequencing is flexible. If it's severe bilateral asymptomatic stenosis or unilateral with contralateral occlusion, CEA before or concomitant is also suggested, grade 2C. The choice between CEA and CAS in this setting is individualized based on timing, antiplatelet needs, anatomy, etc., grade 2B. Overall, lots of weak recommendations, low-quality evidence, emphasizing the need for careful patient selection and shared decision-making. Is that about right?
That's an excellent summary of a complex area with significant uncertainty.
Final board question, then.
Let's wrap it up.
A 70-year-old male presents with unstable angina and also had a TIA 1 month ago, traced to a 60% symptomatic right internal carotid artery stenosis. He needs urgent CABG. He also clearly needs carotid intervention. What's the most appropriate approach to managing his combined disease? A. Perform CABG first, then evaluate for delayed carotid endarterectomy, CEA. B. Perform carotid artery stenting, CAS first, then proceed with CABG. C. Suggest CEA before or concomitant with CABG with the exact sequence depending on clinical presentation and institutional experience. D, proceed with CAG only as the carotid stenosis is not severe enough to warrant intervention. Final pause. The answer is
The best answer reflecting the guidelines is C. Suggest CEA before or concomitant with CABG with the exact sequence depending on clinical presentation and institutional experience. This aligns directly with recommendation 5.1 for symptomatic stenosis, 50-99% requiring both procedures grade 2C. It acknowledges the potential benefit of addressing the carotid lesion perioperatively, but respects the flexibility needed. Option A carries the risk of stroke during CABG from the untreated symptomatic lesion. Option B, CES first, isn't necessarily preferred over CEA for a standard risk symptomatic lesion, per question 2, and the sequencing isn't mandated. Option D is incorrect because his 60% stenosis is symptomatic from the recent TIA and clearly warrants intervention.
fantastic. That brings us to the end of the questions, outro. And that really wraps up our deep dive into these updated Society for Vascular Surgery clinical practice guidelines for extracranial cerebrovascular disease. Wow, what an incredible amount of detail, expertise, and just nuanced decision-making goes into crafting these recommendations.
It really does. And if you connect this to the bigger picture, these guidelines truly reflect our evolving understanding of this disease. They emphasize evidence-based, but also very patient-centered care.
Yeah.
They provide, I think, much-needed clarity in some really complex clinical scenarios, from managing that asymptomatic stenosis we started with, all the way to navigating combined carotid and coronary disease.
So what does this all mean for you, the specialist clinician listening? Hopefully it means you now have a really comprehensive grasp of the latest recommendations. You can feel confident you're providing the most informed, the most current care for your patients. We've genuinely tried to give you that shortcut to being well-informed, going way beyond just a quick summary.
Indeed. We covered the recommendations themselves, but also the why, the evidence base, the grade levels behind them. And the fact that these guidelines are continuously updated really speaks to how dynamic medicine is. The effort to refine them is ongoing.
Absolutely. So, as we conclude this deep dive, we always like to leave you with a final thought, something to mull over. Here's one. How might future advancements maybe think about advanced imaging, giving us even more granular detail on plaque vulnerability beyond just percent stenosis? Or perhaps novel biomarker panels that could predict stroke risk much better? How might these kinds of technologies further refine these guidelines in the years to come, allowing for even more precise, personalized risk stratification and intervention timing?
That's a fascinating thought, really pushing the boundaries beyond our current tools and knowledge. Something definitely to keep an eye on.
Well, thank you so much for sharing your expertise today.
My pleasure.
And thank you for joining us on this deep dive. We look forward to exploring more fascinating topics with you soon on the deep dive.